Greetings, welcome to the cardiac arrest simulation training video for the SLCFire Department. This is Dr. Scott Youngquist, Medical Director. The current scenario is one of unwitnessed arrest. Before we get started, let's go through the algorithm, which I think you all know. But just as a reminder, it's kind of a cyclical algorithm because we're doing cycles of every 2 minutes we're switching CPR providers, and that's to prevent fatigue, especially unrecognized fatigue amongst providers, and keep hands fresh on the chest so that we provide critically good CPR for the patient throughout the resuscitation. So there's a 1, 2 second, 3 second pause as we try to seamlessly transition between CPR providers, but other than that, our CPR can be mostly continuous. Now with see-through CPR, we can see during CPR whether the patient has an organized rhythm typically, or whether they have coarse VF. It doesn't filter out all of the artifact, and so you have to be careful to look for an organized rhythm in there, and if you're uncertain, you may have to check during that brief pause between the switchover between CPR providers. When you're going to do that, charge the defibrillator in anticipation of delivering a shock, and as they pause, you can see if that CPR artifact, as that disappears, if there is a shockable rhythm underneath, or if it's just asystole with some residual artifact. Other than that, you can continue CPR throughout the resuscitation typically. So early defibrillation when possible and good CPR throughout the resuscitation are the important points. The meds, epi for anybody who doesn't come back after the first shock, so anybody who's not a one-shock wonder, you give epi to. Every 3 to 5 minutes. Try not to overdose that. We want to spread those apart and not just give them a lethal dose of epinephrine every minute giving epi. Amiodarone is for the patient that remains in VF or VT, or VF or VT recurs after a first shock, and can repeat that at 150 milligrams, and then we're giving intra-arrest chilled normal saline as well. Use end-tidal CO2 whenever possible to gauge the adequacy of the CPR and to monitor for return of spontaneous circulation. It's much better than checking a pulse. Airway management, I've changed this up a little bit. We've been doing passive ventilation for every arrest, regardless of whether it's witnessed or not. And we've often been doing it, even though I said a respiratory arrest, we shouldn't use passive ventilation. We've done that on a few. So I want you to think about it a little bit in a little bit more complex way. It's not too hard, but just think of it. Anybody who's not a witnessed arrest has probably been down a long time and so could use early assisted ventilations with bag mask or King LT. You can place the King LT easily during CPR, and remember to give a breath every 8 to 10 seconds. You don't want to be breathing for them every second and hyperventilating the patient, but you can start with early assisted ventilations for the unwitnessed arrest. Now for witness arrest, you just have to ask yourself, is this a cardiac cause, or is there some other indication that this was a non-cardiac cause? It's a pediatric patient, it's an overdose or strangulation, drowning, it's a really young person. They probably overdosed on something. If there's a bunch of heroin needles laying around or it seems suspicious, just start early ventilation as if there is a respiratory component to it. Some young people do have primary ventricular fibrillation, but it's much more common for them to have a respiratory arrest from drug overdose or something like that. So anybody who's a witnessed arrest that is presumed to be cardiac in nature, we do the passive ventilation for the first 6 to 8 minutes while we prepare to put in a King LT, or attempt endotracheal intubation if we want to be daring, but King LT is foolproof. So let's go into this resuscitation. Respond, there's been no bystander CPR, checking for a pulse.
We take your airway, put on a cap, no mask, and you guys start compressions. Clap, we get an IO established.
The lead paramedic gives some directions, and we start with the most vital intervention, which is really good CPR. You notice the palms are coming off the chest. He's doing a rate of about 100 per minute. Good depth of at least 2 inches.
Patches.
Try not to stop. Commanding officer with a really great mustache is recording the scene and acting as the timekeeper so that they help switch people over.
We have an IO established, and I hung some cold fluids.
CPR. Show VTAC on the monitor.
He's identified a shockable rhythm very early. He's counting down in case the person wants to get off the chest. After 1, he delivers a shock. It's perfectly safe to do that with gloves on.
Let's go with a milligram of epi and 300 of amiodarone.
He's still got a shockable rhythm on there, so that's why he's giving the amiodarone. The patient
It looks like he's gone to
still in VF now.
Epinephrine and amiodarone have been administered.
Copy that, thank you. We're up 1 minute in, fellas.
So we've already delivered a shock
Patient's in defib, charging.
within a minute of responding. Very good early defibrillation.
And shocking in 3, 2, 1. Still showing defib.
With see-through CPR, he doesn't have to stop to see whether the shock has worked or not.
Get out.
In most cases, it's not perfect, like I said. Asystole is hard to tell. Initial airway was chosen as a capno mask in this case. This was an unwitnessed arrest, so he could start with some early bag mask ventilation. In fact, he goes to the King LT fairly early after
20 on end-tidal.
just a minute or two of passive ventilation.
And patient is still in defib, charging.
It's following the end tidal that he's getting on that capno mask. Make sure the airway is open for the capno mask.
Shocking in 3, 2, 1.
2 minutes in. I'm going to apply the King airway now.
Okay.
So they switched
And patient is still in defib.
CPR providers a little early because the first guy was getting tired. But normally we do that every 2 minutes, so we'll only let people stay on the chest for 2 minutes at a time.
Shocking in 3, 2, 1. Looks like patient is now in asystole. Checking multiple reads.
Remember, asystole is
King airway is easy to bag. King airway size 3 was in.
All right.
asystole is
Stand by with the milligram.
successful defibrillation. Everybody goes into asystole if they're successfully defibrillated, at least for some period of time, maybe a minute, 2 minutes before a native rhythm comes back.
Ready, Will?
I like how he's bagging at a real slow rate, 8 to 10 a minute or so,
Next dose of epi.
counting probably in his mind 1 Mississippi, 2
Epinephrine
Mississippi,
is on
3
board.
Mississippi, 4 Mississippi. It's good closed loop communications.
Let's check the blood sugar.
Paramedics, the lead paramedic here
Still showing end-tidal of 20. I'm going to call this PEA.
has recognized that there's an organized rhythm, but
Dave, the blood sugar's
the end
96.
tidal is still so low that he knows he's not getting good perfusion yet, so we're going to continue to support him. There's
All right, we just
unlikely to
had a
have
spike in
a
our end-tidal.
detectable pulse.
Full compressions.
Now he's prompted to stop and check for a pulse
Patient has a
because of
pulse.
that spike
Let's
in
go ahead
end
and get
tidal
some vitals.
CO2. It's gone up.
Hook him up and do a 12 lead. If you'll intubate him, AJ. And if you'll get some cold saline started.
So this works best if everybody operates sort of on autopilot and the lead paramedic acts as sort of the symphony conductor rather than somebody who's
We
trying
have bilateral IOs,
Giving
and we're running cold
people
fluids.
cello lessons and violin lessons during the resuscitation. You want that pit crew approach.
Anything else?
How about some ice packs?
Let's get some ice bath.
Post arrest, they get a 12 lead, they're cooling him, they're going to go ahead and intubate this patient. This is a recording from an actual cardiac arrest that we had. Patient received an inappropriate shock, but it was because of the leftover artifact from the see-through CPR. And it can be hard to tell sometimes when there's a lot of residual noise despite the filtering algorithm whether the patient actually has a rhythm, if this is VF, or if there's just quiet asystole underneath and all of this is residual noise from the CPR. In this case, you can clearly see these QRS complexes. They're sort of like a drowning man poking his head above water in a choppy sea. There's still a lot of noise because there's ongoing CPR, but those organized complexes that recur are a sign that this patient at least has pulseless electrical activity. In fact, they may have return of spontaneous circulation because you can see up above the end tidal CO2 is at 45, which is really high. We have been achieving that with CPR in patients that are pulseless, but it's a good indication this guy's probably got a pulse back. And so the shock that's delivered at the end of this rhythm strip is not indicated for this patient. Does it hurt a patient to deliver a shock when it's not indicated? Certainly doesn't hurt for somebody who's in asystole. Somebody who does have a pulse and is generating cardiac output, it's probably not harmful once or twice as well in those patients to give them inappropriate shocks. It's not desirable, but it's better to shock when you think it's possible that the patient has a shockable rhythm than to not shock when they do have a shockable rhythm. In the case of exquisitely bad timing, you may cause an R-on-T shock and put them back into ventricular fibrillation, but the treatment for that is another shock. If you give a lot of shocks to somebody who has a perfusing rhythm, that can cause some myocardial stunning and reduce their cardiac output, but otherwise it's not a big deal. I just point this out so you guys can recognize those QRS complexes. In cases of asystole, as I mentioned, you're going to have to change your strategy a little bit. You can attempt shocking that, but if it seems like it's just CPR artifact, you may want to wait to deliver the next shock until the end of that 2-minute cycle. When you're switching over providers, just have them pause in their transition a little bit longer so you can see whether it is asystole, but pre-charge the defibrillator in advance, anticipating a charge, and just cancel the shock if it turns out it was all just a bunch of artifacts.